Good morning, dear doctors, and good evening or good afternoon to anyone who watches my videos. In the name of God, I want to start today's lecture. Today is the second lecture of neurology. We did the first lecture, and in the first lecture, I received good feedback and good comments that it was helpful. So I hope the second lecture is better than first lecture. In the second lecture, we are going to study posterior fossa malformation. At first, we need to know when we say posterior fossa, what do we mean by posterior fossa? Posterior fossa means the in back of our head. So in back of our head, according to anatomy of the neuro, we know that in the back of the head there is cerebellum, medulla, and pons. They are all together. They're like neighbors and they're like three friends. And the embryologic portion of these three organs was metencephalon and myelencephalon, if you remember, and rhambencephalon was the precursor of all three. So whenever you are trying to talk about an organ in each system, try to remember the embryology on that lesson, even if it is not written in first aid. You can just revise it just to stick it in your mind and not to forget it. So now that we are talking about posterior fossa malformation, we need to know that posterior fossa is in the back of the head. Posterior fossa has three organs, like three main organs, like cerebellum, medulla, and pons. They are all together in the back, and the precursor of all of them, from embryology, it is metencephalon and myelencephalon. So whenever we see malformation in this posterior fossa, it means that we see something not formed properly in the posterior fossa, and those organs that are in the posterior fossa are cerebellum and medulla. So whenever we say posterior fossa, there is also a foramen which is called foramen magnum, and this is a big foramen in which lots of parts of brainstem, like arteries, nerves, are coming down and up. So this fossa, this foramen is made for the neurons to go up and neurons to come down, and to the arteries to to go up, and also a part of brainstem which is connecting to the spinal cord. So this fossa has this foramen has a big purpose. But whenever in this foramen we see that the organs which are not supposed to be down, they are coming down. That's called posterior fossa malformation. For example, we have here uh, Chiari 1 malformation and Chiari 2 malformation. Malformation means that an organ is not formed in the way that it should be formed. So Chiari 1 malformation and Chiari 2 malformation, I used to memorize it like this. I didn't say Chiari 1 or Chiari 2. I will say later why I changed the name, just to remember it easily. At first, let's read it. Downward displacement of the cerebellar tonsils through the foramen magnum. We already said that foramen magnum is a foramen or a big hole in the back of the brain, in which a part of brainstem is coming down to connect with the spinal cord, and also some arteries and some nerves are coming up and down. So this foramen is made for this purpose. But whenever cerebellum, which should be in posterior fossa, which should be in the back of the head, it is coming down, especially the tonsil. If the tonsils are coming down, this is called Chiari 1 malformation, usually asymptomatic in childhood, and just sometimes in adulthood, it is associated with headache. And there is also a spinal cord association with Chiari 1 malformation, which is called syringomyelia, which is going to be explained later today. So Chiari 1 malformation, I used to say Chiri. Chiri 1 malformation. Chiri is a type of fruit like this, right? I'm not good in writing. So chiri is a fruit like this. So whenever we say Chiri 1, Chiri 2, according to the name, I remember that something is like swinging down. So however, it is Chiari 1. I used to say Chiri 1. It means that one Chiri is dropping down. So one Chiri is dropping down. It means that the cerebral tonsils, like a Chiri, is coming down to the from the foramen magnum to the spinal cord, and also the association is also one association in the spinal cord. So Chiari 1 malformation, a part of the cerebellum, just the tonsils are coming down. So this is one malformation, and the association is also one association. in spinal cord, which is called syringomyelia. Whenever we say Chiari-2 malformation, now according to my mnemonic, Chiari 1, this is Chiari 2, it means that two organs are coming down. So downward displacement of cerebellum with medulla. So two organs are coming down. Which part of the cerebellum? Vermis and the tonsils. Even the parts of the cerebellum is two, it is not one. So whenever we say Chiari-2 malformation or Chiari-2 malformation, we mean that two organs are coming down from foramen magnum, cerebellum, and medulla, which all of them should, both of them should be up. So these are two structures. They are coming down through foramen magnum, and they are causing non-communicating hydrocephalus. Because we know that according to embryology lecture from the other day, we know that cerebellum, pons, and medulla, they are all three together, and they have a ventricle which is called fourth ventricle, right? So whenever cerebrum and medulla comes down, it obstructs the way of the fourth ventricle. So all of the CSF which is in the fourth ventricle cannot communicate to the other part of the body. Like it cannot come out of the fourth ventricle. So like we have two foramens, Lushka and Mijindi, right? That we are going to explain it later. So whenever we say non-communicating, it means no communication. It means that whenever we say non-communicating hydrocephalus means that the lots of CSF is obstructed in the or maybe we can say that a lot of CSF is inside the brain. And whenever we say non-communicating means that this CSF, which is accumulated in the inside the brain, it is because of no communication. Non-communicating, no communication. Whenever you say like this, it will be easier to remember. When we say communicating hydrocephalus, it means that CSF is a lot, but there is communication. It means that the ventricles have communication with each other, but still the CSF is more. So according to the name, we can understand the cause. If we say communicating hydrocephalus, it means that the CSF has a lot of production, or maybe the absorption is decreased. So communicating hydrocephalus means like this. Whenever we say non-communicating hydrocephalus, it means that the problem is not with absorption, the problem is not with production, but the problem is with the communication, because the ventricles don't have communication, no communication with each other. That's why the CSF has accumulated inside the brain. So, and here it makes sense because cerebellum and medulla, when they are coming down, they obstruct the way of the fourth ventricle, and they make non-communicating hydrocephalus or obstructive hydrocephalus. This is more severe than Chiari 1 malformation. Chiari 1 malformation, there was one organ coming down, and there was one association like syringomyelia. Usually presents early in life with dysphagia, stridor, apnea, limb weakness. We don't need to memorize every single word. Just we should know that function of cerebellum and the function of medulla. We know that the cerebellum and medulla are friends together. They are in the back of the brain. Um, cerebellum has the function of keeping the balance of our body and making the movement smooth, right? And medulla has a lot of centers, like respiratory centers, like a lot of nerves, cranial nerves are coming out of medulla, like cranial nerve 12 is coming out of the middle of medulla, and the 9, 10, 11 cranial nerves are coming out of lateral medulla. So whenever we say that medulla and cerebellum are coming down, it means that their function is also impaired. So the function of medulla was like cranial nerve 10, which is vagus nerve. It's coming out of medulla from the lateral side, so it will cause dysphagia. We don't need to memorize dysphagia. We already know. Whenever somebody asks us that which sign and symptoms do you see in Chiari-2 malformation, you should first remember that it is the displacement of cerebellum. So whenever cerebellum is displaced, the function of cerebellum is balanced. The patient will have a problem in balance or walking. And whenever we say that displacement of medulla, we know that from medulla, lots of cranial nerves are coming out. So the patient will have stridor because vagus nerve helps with some branches of vagus nerve helps with the larynx, right? Like laryngeal branch of vagus nerve. And dysphagia, the 9 and 10 nerve, both of them help with the eating and swallowing. So apnea, it means that the respiratory center is also in medulla. Limb weakness, because most of the tracts are crossing medulla. So like motor neurons, sensory neurons, all of them are crossing medulla. So We don't need to circle these and memorize these, because that will be like a passive learning. We need to find the main part of the lesson. So when we know the function of cerebellum and medulla, and whenever we see that there is a problem with these two, we know that which problems are going to, which symptoms and signs are going to appear in the patient. So as I already said that in theory, one malformation, we had one organ displacement and one association. One organ displacement was cerebellar tonsil displacement, and the association was syringomyelia. But theory two malformation, we said that it is cherry two. These two cherries are down. One is cerebellum and the other is medulla. And I said the association is also two things. Actually, it is one word, but it contains two things. Myelo-meningeal. Myelo means that the spinal cord itself, the nerve tissue, the inside the spinal cord, and meningeus means the cover of the spinal cord. So two things are coming out. Two things: cerebellum and medulla, myelo and meningeo. Seal. Seal, as I explained in my last lecture, that seal means a bag. Whenever we say myelomeningocele, it means that the nerve tissue and the meninges are all inside a bag, and it's coming out of the lumbosacral area. So theory one malformation and two malformation, it is easy to read all of them word by word, but it is difficult to maintain and remember it. When once we finish all first aid book, it is difficult to remember each and every single word. So the trick is to just say here, one malformation, one structure is coming down, which is cerebellum, and one association, which is syringomyelia. And theory two malformation, two organs are displaced, cerebellum and medulla, and the function of these two are impaired. And myelomeningocele is also the association. So Dandy Walker is another malformation in the posterior fossa, agenesis of cerebellar awareness. We know that cerebellum has like two hemispheres. Cerebellum is also like a small brain. It has two hemispheres. One is this hemisphere and the other is this hemisphere. This side is called vermis. Vermis, we used to write it like this. This is the cerebellum, and this is these are the hands of someone, and these are the feet. If we consider it as cerebellum, we know that vermis is at the middle side of the cerebellum. So we just consider it like a human body. These are the wings. So wings of the cerebellum makes the hand movement, has the function of hand movement. Vermis is the middle part of cerebellum, which is making which has the function of thorax movement and feet movement. So whenever we say that agenesis of cerebral vermis means that this part of cerebellum is not made. Whenever this part of cerebellum is not made properly, the truncal movement and feet movement will not be properly adjusted. So agenesis of cerebral vermis means that the cerebral vermis is not made. So whenever an organ is not made, the place of the organ appears like a cystic enlargement in the fourth ventricle, means that the fourth ventricle becomes happy because it has a lot of space to capture, right? So we say that agenesis of cerebral vermis, the vermis of the cerebellum is not made. So we know that whenever vermis is not made, the patient will have ataxia, like the patient will not be able to move properly. And the place of the organ appears like a cystic lesion in the fourth ventricle, like this. And that fills the enlarged posterior fossa, and the fourth ventricle occupies the space. It is associated with non-communicating hydrocephalus. Again, the same thing, because we said that hydrocephalus means that a lot of CSF is built up in the CNS, and non-communicating means that it is the hydrocephalus or the buildup of the CSF because of no communication with ventricles. If it was communicating, we used to remember that communicating means that all the ventricles has communication with themselves. So the problem in communicating hydrocephalus is either absorption or production. So whenever we say non-communicating, we know that there is an obstruction. And so the association with this is spina bifida or hydrocephalus. So the way I used to remember this we usually don't see a lot of questions from these parts. Just they are showing a picture like this in the exam, and in BMIS or you work, you see this picture, and these arrows are also the same. They don't show the arrows because in the question they don't want to point out so that everyone understands it. Just they show this picture without arrows. Whenever you don't see the arrows, you see that this is cerebellum and a part of cerebellum is coming down. So you know that this is cerebral tonsil coming down and making theory malformation. The second picture that I'm going to show you, this is an MRI. So how to know that we are looking at an MRI or a CT scan? We know that CT scan, whenever we are doing CT scan, we are looking at the bones. We want to see the picture of bone, what is happening in the bone. But whenever we order an MRI, we are looking for soft tissue, for nerve tissue. So how is the difference whenever we see? How do we know that this is MRI or this is CT scan? Whenever you see that soft tissue is white, and this you see that this is white, right? This is and this is cerebellum, right? We see that cerebellum is made, but the vermis is not made, and this place is occupied by CSF and like a cystic lesion. So according to imaging criteria, we know that whenever we see uh, whenever we say a cyst inside the cyst should be dark or black, right? In ultrasound and imaging, whenever we see something black, it is cyst. But here we see that we see a white area. It means that whenever we are doing CT scan or ultrasound, we see cyst like a dark lesion, right? It is black. But whenever we see that this cystic lesion is appearing white, it means that we have done MRI, because MRI is focusing more on soft tissue. So this place is white, but this is not bone. This is not hemorrhage or anything. This is MRI of the brain. And overall, whenever you're confused, if you're looking at the CT scan or if you're looking at an MRI, because we are not radiologists, just an overall idea. Whenever you are seeing that the brain tissue is white and the bones around, they are not very white, so it means that you're looking at an MRI, and the purpose of MRI is to look at the soft tissue. Whenever we want to see the brain tissue, whenever we want to see the nerves, the ligaments, so we order an MRI. But whenever we want to see the bones, or we want to differentiate between hemorrhage or ischemia in the brain, we order CT scan. And in CT scan, you see that the bones are appearing white and the brain will appear black in CT scan. So when you see a whitish brain, it means that this is an MRI. Whenever we see a whitish bone, we know that this is a CT scan. So mostly from this part of the first aid, I have usually seen questions on step 1 and step 2 that they are showing a photo, either MRI or CT scan, and they are asking you for the malformation or association. Whenever the medulla and the cerebellum is down, according to the sign and symptoms, you can also understand, even if you don't understand the full picture, because the question says something about like the patient has dysphagia, the patient has stridor, so you know that medulla is also involved. You know that this is KRE2 malformation and the association is meningeal. Whenever you see that the patient only has ataxia and not walking properly, so you know that this is possibly Dandy Walker. And how to remember Dandy Walker? Walker means walking. Dandy Walker means different walking, means difficulty walking. So we know that walking is controlled with cerebellum, and possibly this patient has a cerebellum problem. So let's move to the syringomyelia. This is another important and interesting part of neurology. However, we are going to study the fibers and neurons and tracts that are going up and down, upper motor neuron, lower motor neuron, dorsal column, and all of them. They are so interesting. And the good thing about neurology for me and my experience was that when you understand neurology, even if you don't repeat it, even if you don't review it, you can understand it, and you can make sense, and you can maintain it, because this is like mathematics, like using formulas. Whenever you understand something, you never forget it. So I'm going to, if we continue with neurology, I'm going to tell you the techniques and the tricks so that you look at the image and find out the problem. And I promise that I will do that for you all. So let's see about syringomyelia. We already said that in Chiari 1 malformation, the cerebellar tonsil is coming down from in magnum, and because only one organ is slightly down, so the patient will not have a lot of symptoms in early life, but later on um, there will be some headache, and also sometimes there is an association called syringomyelia. So what is syringomyelia? Syringomyelia means that there is a uh, fluid-filled gileuous-like cavity within the spinal cord. So the way I used to remember it, that we use syringes for the injection, right? Whenever we push up and pull out the syringe, there is a lot of air inside the like a space inside the syringe. So I used to remember like that a syringe inside the spinal cord means that a space which is filled with fluid inside the spinal cord. We know that this is a transection of the spinal cord, and this is the dorsal part of the spinal cord. This is the anterior part of the spinal cord. These are the lateral part of the spinal cord. We know that the dorsal part of the spinal cord and the CNS, they are developed by BMP protein, as we did in our last lecture, and the ventral part is developed by Sonic Hedgehog gene, right? We remember those. So this is the ventral part, this is the dorsal part, this is the posterior part, this is the anterior part. Posterior part of the spinal cord is usually they are carrying the sensory output, and the anterior part is usually taking the motor input. So this is sensory, this is motor, this is dorsal, this is anterior, this is dorsal, this is ventral. So just whenever you see a spinal cord, try to uh, repeat it again and again so that your eyes are used to understanding which part of the spinal cord you are. So fluid-filled gileuous line cavity with spinal cord. So it means that whenever we say glial cell or gileuous, we know that these are non-neuronal cells. So a cavity inside the spinal cord. Of course, there is a central canal in in the middle of the spinal cord, but this central canal is not. This is for the this central canal is not in the just to be filled with a fluid or to have a cavity. So whenever we see in a part of the spinal cord, there is a cavity which is it is filled of fluid. So we know that this is syringomyelia. Fibers crossing an anterior white commissure, which is called the spinothalamic, are typically damaged first, and it will cause cape-like loss of pain and temperature sensation in bilateral upper extremities. So, let me explain this for you because this is very important. We will look at the photo. Let me mute some of the doctors because I see, I hear some. Okay. So let me share the screen. Okay. So let's see. Let's look at the picture because unless we know the mechanism and the pathways, we will not understand any word of the first aid. So at first, we know that this is a spinal cord, and a spinal cord has the function of connecting the environment with the brain. It means that it takes all the information from outside to the brain and brings all the information from brain to outside. It means that we have neurons, and just imagine this is the periphery. So all the neurons from periphery goes to the brain through a spinal cord. It means that we send information from outside to inside the brain. So these are called afferent neurons. Afferent neurons means that the neurons that are going to the main part of the system. Anywhere, whenever you see afferent and efferent. Afferent means arrive. This is a common mnemonic, and efference means exit. So most of the time when I was studying, I used to be confused that where to arrive from where to exit. So whenever you see afferent in each system, just remember which part of that system is the main organ. Like whenever you are in neurology, you know that CNS is the main organ or main part of neurology. Whenever you are in renal section, just imagine that glomerule is the important part of the system, right? So whenever you see afferent neurons, it means that the neurons that arrive to glomerule, the neurons that arrive to CNS. So just imagine like this. Whenever we say afferent, it means that they are arriving. Where they are arriving to? They are arriving to CNS. So this is afferent nerves. So whenever we see efferent, it means that they are exiting. From where they are exiting from? They are exiting from the main part of the system. Main part of the CNS system is brain, and main part of the renal system is glomerule. So just try to make it easy for yourself not to forget it, because whenever we say afferent, so here now we are saying afferent neurons. Afferent means that they are going to the brain, they are arriving to brain. So afferent neurons should be which type of neurons? They should be neurons that they are arriving to brain. So this is afferent. So these afferent neurons can be sensory information. Sensory information or afferent neuron, they are equal. Either if we say sensory information into the brain or afferent neurons into the brain, it means that afferent neurons take the sensory information from the periphery and takes it to the brain. So sensation, for example, the sensation of pain, the sensation of temperature, the sensation of vibration, the sensation of proprioception, vibration, position, all of the sensation, they are taken from the neurons from outside, from periphery, and they are taken into the CNS. These are called sensory neurons. And then the brain sends back with efferent neurons. What does brain sense? Efferent means exit. The neurons that exit from brain and come to the periphery. So the neurons that exit from the brain and comes, these are motor neurons. Okay. So now we understood that sensory information, they are taken from the periphery with the neurons, and those neurons take the information to as afferent neurons to the brain. And then the brain analyzes it and then sends the motor feedback with efferent neurons to the periphery. So now it makes sense that whenever we say sensory information to the brain, we mean that afferent neurons, they should go to the brain. Whenever we say motor information, we now know that these motor information should come out of the brain to the periphery by the motor neurons. The sensory information is going from the periphery. Now let's do the sensory information. Whenever we say that these sensory information like pain, temperature, vibration, all of these are sensory information. All of them are taken from the periphery, right, with the nerves, and these nerves cannot go to the brain by themselves. They should go to spinal cord, and spinal cord sends them to brain, because spinal cord is a part of CNS and it has connection with the brain. So whenever we take a sense of pain, sense of temperature or whatever, at first this sense goes to the spinal cord, and this nerve, in your opinion, this nerve should go to this part or should go to this part of the spinal cord? Which part? Anyone can tell me?
Backside, because it's sensory.
Exactly. Yes. Thank you so much, doctor. So, as the doctor said, I forgot the name. Sorry for that. Because I cannot see the screen when I'm sharing my iPad screen. So, as the doctor said, the sensory information is taken from outside or from periphery. It should go to the brain. In order to go to the brain, this sensory information should enter the spinal cord, and the spinal cord will send it to the brain. So, because it is sensory information, it is pain, it is temperature, it is vibration, it is position, it is proprioception. So, all of the sensory information should go from dorsal column, because this dorsal column is made to take the sensory information. This is called sensory part of the spinal cord. It means that this part of the spinal cord is collecting all sensory information. And whenever we say ventral horn or motor part, This is Sonic Hedgehog gene made this part of the spinal cord as motor or ventral horn. So this part is for motor information. So it means that all sensory information should find their way to the sensory part of the spinal cord, and this sensory part of the spinal cord will send all the information to the brain. And then the brain, again, whenever the brain wants to send the feedback, brain also uses a spinal cord. Which part of the spinal cord? Brain sends all the neuron information to the spinal cord, and then the spinal cord sends it to the periphery. So this is how the brain communicates with our body. Does it make sense? I hope I didn't confuse you, because I'm sure that most of you all, know a bit about neuro, but this is the way I used to imagine the brain communicating with our body. So now that we are talking about pain and temperature, so pain and temperature means that these are sensations. So these sensations are taken from our body, and they are taken to the spinal cord, and they should reach to the brain. So all of the afferent or efferent neurons that they are going to the brain, they need to cross. Cross means that the information from left side of our body will be evaluated to the right side of the brain. So it means that neurons from the left side need to cross and reach to the right side of the brain, and neurons from the right of the brain should cross and come to the left of the brain. This is something that we all know about that. So these pain and temperature tracts or neurons, how they go to the brain. So these are called afferent. Why they are afferent? Because they are sensory, and they arrive to the CNS, right? They arrive to CNS, right? This is afferent. So how does it arrive to CNS? They should go to the dorsal part of the spinal cord and arrive to CNS. And this is called lateral spinothalamic tract. The way I used to remember, and believe me, it made my life so easy. I didn't need to think a lot about which tract is taking which type of information. Whenever you say spino, I used to write it spino, just to remember that this spinothalamic is carrying the pain information. And instead of thalamic, I used to say temperature. Spinotemperature tract. It means that it is carrying pain and temperature. This was one mnemonic that was so helpful for me. And whenever I used to say spinothalamic, so in one way, I used to remember that this pain is pain and this thalamic is temperature. I used to know that this tract is carrying pain and temperature information to the brain. And on the other way, I used to understand it the way like this. Spino, it means this sensory information starts from the spine and it goes to thalamic. Thalamic is in the brain. We know that thalamus, hypothalamus, everything, these are in the brain cortex, right? So a spinothalamic makes two things easy for me. The first thing is that how these neurons are going, which way they are using. They are going from spine to the thalamic, from spine to cortex. And the other way, they are taking pain and temperature. Believe me, if you just trust me and use this mnemonic, you will never make a mistake with the spinothalamic tract. You will always remember it, because I have the experience and it was so helpful for me. Whenever I used to see in a question that pain and temperature, I used to know that this is spinothalamic and this is going from the periphery to the brain. Let's do another game. If we say cortico spinal. So what does it mean? It means the tract is coming from cortex to where? To spine, right? From cortex to spine. Now this is these neurons are different. They are coming from cortex to the spine, so they should be efferent, right? They should be motor. Just read the name of the tract and understand how it does. Don't memorize all of them. Just when you say spinothalamic, it means that it is starting from spine and it is going to thalamus. Start from spine, goes to thalamus. It means it goes from periphery to the center. It is afferent. And it is, and of course, afferents are all sensory information. Whenever we say corticospinal, it means that it is starting from cortex and it is coming down to spine. It means that this is not sensory. This is efferent. These are efferent fibers, and these are sending motor information. Now, however, we are in the first or second page of neuro. We know that we have two tracks. One is afferent that takes sensory information to the brain, and the other is motor fibers that they are bringing motor information from the brain to the spinal cord. Are you with me?
Yes.
Does it make sense now?
Yes, perfect.
So, thank you, doctor. Now we understood about spinothalamic. So we don't only have pain and temperature sensation. We also have other sensations like we have sense of vibration. We know the sense of like other senses, vibration, position, proprioception. For example, if you now that you're looking to the book, you already know that you are sitting in a chair. This is also a sense of proprioception. You understand that you are sitting on a chair without looking at the chair, right? Whenever you are standing, you understand that you are standing. When you elevate your hand, you know that your hand is in the upside. So whenever you are shaking your hand, you know that your hand is shaking. So these are all sensation of proprioception. When your phone vibrates, you sense the vibration. This is a sense of vibration. So these are also sensory information that they are also taken from the periphery and environment, and they are taken to the brain. So all sensory information goes to the dorsal column, and this sensory information goes through the dorsal column, not the spinothalamic. Spinothalamic is only for pain and temperature. Temperature thalamic, right? And temperature tract. So as I said, that all the nerves that go up and come down from the brain, they should cross, because brain, right side of the brain controls left side of the body, and left side of the brain controls right side. So these fibers should cross. The problem with spinothalamic is that other tracts like motor tract, as we said, corticospinal tract, right, which is coming from the brain, it crosses in medulla, and also the dorsal column, these columns, the sensory information for pain, for vibration, for proprioception, for position. These sensory information and corticospinal tract, all of these tracts, either motor or sensory, they cross in medulla. The only exception is the spinothalamic. Spinothalamic does not cross in medulla. The spinothalamic, as the name says, it crosses from the spine. It means that the information from spinothalamic from the left side of the body right away crosses the spine and goes to the brain. Why does it do like that? Why spinothalamic can't wait until reaching to medulla? Because spinothalamic, it is in the lateral. For example, if we take the sensation of pain and temperature, this tract wants to go to dorsal column, because dorsal horn, these are dorsal horn, and these are dorsal column. All the sensory information should be collected here. In order for spinal thalamic tract to reach the dorsal column, it cannot cross right away. It cannot reach like this. It needs to cross like this just to make it regular. That's why spinothalamic tract cross the spinal cord right away. It doesn't wait for the medulla. Other tracts, like dorsal column tracts and corticospinal tract, for example, sense of vibration, sensation, position, proprioception, all of them, they just go to the medulla, and they cross in medulla. And corticospinal tract, which is coming down, they are also crossing in medulla. We are going to study all these columns in their section, because it is not the time to read all of them, because we are not done with anatomy and physiology. Just it was it was an information to not to confuse this lesson. So let's go ahead with spinothalamic. So now that we know that the spinothalamic is a tract which goes from spine to the thalamus, from periphery to the center, and it takes the pain and temperature sensation. This is an exception to the rule, because this tract crosses the spinal cord and goes to the other side of the spinal cord, and it finds its way to the brain. At the same time, the other side of the spinothalamic tract crosses the spinal cord and goes to the brain. So it means that the spinal cord, in the center of the spinal cord, the only tracts that we have is the spinothalamic tract. Whenever we have syringomyelia, it means that there is a cavity in the middle of the spinal cord. This cavity pushes these nerves. Why these nerves? Because these are the only nerves that cross inside the spinal cord. Motor horn, these are motor neurons, and these are dorsal column. They will not affect. They will not be affected when it is a small. When it is big, like big syringomyelia, then of course the syringomyelia will affect the ventral horn as well. That this is a step 2 concept that they usually ask in step 2 central core syndrome, and that the syringomyelia is big enough, like this one. If the cavity is so big, of course, that will affect the ventral horn as well. But here you see that the syringomyelia is only in the central cord, a small cavity, and this small cavity affects the neuron fibers. Which neuron fibers? The fibers that are crossing the spinal cord, and these are called spinothalamic tract. So whenever we understood the mechanism of the spinothalamic tract, and we understood that syringomyelia is pushing or stopping or blocking the way of spinothalamic tract, so patients with syringomyelia will have loss of pain and temperature sensation. We know that why loss of pain and temperature, because the spinothalamic tract was crossing the middle of the spinal cord, and syringomyelia pushed it back and stopped the fibers to go up to the brain, and the temperature and pain sensation was affected. It is in dermatom C5 to T4. It is called cape-like distribution. Cape is a type of clothes that Superman is wearing, right? Cape-like distribution means that the patient will not have the sense of pain and temperature in upper body. I've using some videos in TikTok or Facebook that people are frying French fries or any type of food with their hand. They don't use a spoon. They don't burn. Sometimes when I see those videos, I remember a spinothalamic tract, because maybe they have problem with their spinothalamic, because anybody who touches something hot, they will feel burning sensation, right? But whenever somebody doesn't have pain in their hands, doesn't feel pain and temperature in their hands, so it means that the spinothalamic tract is affected. And syringomyelia, you usually see questions that they say that they have cape-like pain and temperature loss, so which tract is affected? We will study the details of these tracts later, and just to know that why it is in C5 and T4, because we are studying syringomyelia and curing of one malformation, which is in the upper part of the body. So, of course, syringomyelia is most often here. So let's see what are the causes. One cause was Chiari-1 malformation or Chiari-1 malformation. Cerebellum was coming down, and it was also causing associated with syringomyelia. And the other causes, let's see. Syrinx in Greek, it means tube or a syringe. Most lesions occur between C2 and T9 in the upper part of the body, usually associated with Chiari-1 malformation, and less commonly associated with other malformation like infection, tumors, and trauma. I used to see questions about trauma and syringomyelia. However, it is rare, less common, but I used to see questions in step 1 and step 2 about trauma and infection. So just remember that a Chiari-1 malformation is easy to remember with syringomyelia, but whenever you see a question that's asking that a patient has a cape-like distribution, loss of pain and temperature, what can be the cause? Look for trauma as well. If the patient has the history of trauma, trauma can also cause it. Infection can also cause it, and tumors can also cause this abnormality. So let me see what is left in the here. So we said that it is a fluid-filled cavity, and the spinal cord, fibers crossing anterior white commissure. It means that the fibers, which fibers are crossing here? Spinothalamic fibers taking the pain and temperature sensation to the brain. These are damaged first. Why? Because they are crossing here the center of the spinal cord, and when a cavity is made in the center, of course, it will affect the center first. If the cavity is larger, then it will cause lower motor neuron deficit. So what do we mean by lower motor neuron? Now we know that motor comes from the brain to the spinal cord, right? What do we mean by lower motor neuron? We said that we have spinal, right? Corticospinal means from cortex to the spine. It means that from fibers are coming from cortex to the spine, so they are motor. First, we need to find what is motor fiber, right? Then we say what is lower motor and what is upper motor. Upper motor means that all the neurons that are in the brain and spinal cord, because spinal cord and brain is called CNS. And whatever neuron that is coming out of ventral horn, this is called lower motor neuron. It means that whenever this cavity is large enough, it will push the ventral horn, and ventral horn is the place that upper motor neuron finishes and lower motor neuron starts. So it will cause lower motor neuron deficit that we are going to study later on. Okay. So I hope you got some information and you like this until now. So let's go to the other page. The first pages of neuro is a little bit memorization, but no worries. We will make it easy and fun to remember it. So now we are going to start the anatomy and physiology of neuro. Most of them I already explained in the first lecture, so most of them are a revision. So cells of the nervous system, we already know that CNS or CNS or central nervous system, it's made of two parts. One is spinal cord and the other is brain itself, and the neurons, the cells are called neurons and non-neuron. We know that neuron cells and non-neuronal cells, which is called glial cell, we already studied the other day. So neurons, they are permanent signal transmitting cells of the nervous system composed of dendrites, cell body, and axons. So first, let's read the neurons. Mute some. Okay, sorry for that. So let's read about neurons. We already know that we have neuronal cell and non-neuronal cell. Non-neuronal cell are called glial cell. We are going to study them here. We already have a little bit information about them. And about neurons, we know that neurons are the cells that are permanent. It means that once the neuron is made, they are permanent cells. They cannot regenerate quickly. Most of the neurons are permanent cells. Signal transmitting, it means that they are carrying information, sensory, as afferent nerves to the brain, like spinothalamic and dorsal column, and motor information from the brain to the spinal cord, which is called corticospinal tract, and those are the neurons that they are signal transmitting cells, and they are doing these jobs. So what are they composed of? They're composed of dendrites, cell bodies, and axons. Every one of us from medical schools, we know that neurons are made of these things. Axons take out information to the other neuron, and dendrites are receiver, axons are donor, and cell body is the place where the neuronal gene and everything is there. So here it also explains. So dendrites, they're receiving input, they're taking input, and axons, they're sending output. We already know all these. So dendrites and cell bodies can be seen on mesial staining. So this is another thing that mostly in NDMEs they are asking about mesial staining. Just we need to remember that whenever we say cell body and dendrite, we have a cytoplasm, we have rough endoplasmic reticulum. So we see mesial staining inside dendrite and cell bodies. Why we see this in dendrite and cell bodies? Because they have cytoplasm and rough endoplasmic reticulum, but not in axons. What is the importance of this? Because whenever we stain nerve tissue and we see under microscope, whenever we see mesial staining or a different color, we know that we are in the dendrite and the cell body. And whenever we don't see any stain, we know that we are in the axon. But sometimes when there is a nerve injury, we don't see a mesial staining anywhere. Like this is called chromatolysis. Chromatolysis means that the chrome means color, right? Chrome. Whenever we say chromatolysis, it means that the color which was able to be stained, which was visible under the microscope, that is lysed. And now we don't know whether we are in the cell body, whether we are in the dendrite, whether we are in the axon. So this nasal spinning just distinguishes between the dendritic part of the neuron and the axonal part of the neuron. Axon doesn't have any rough endoplasmic reticulum. That's why it doesn't stain with nasal staining. We are going to study chromatolysis next day because this is also another topic that we are going to discuss. Just here, we need to remember that whenever we stain a nerve tissue, and we see a staining or a different color, we know that we are in the dendrite or cell body. And whenever we don't see any stain, that's the axonal part. What are the markers of neuronal tissue? This is also very important. Marker means that whenever in a question or whenever in a biopsy, we see a cell. For example, whenever we send a cell to a pathologist, we don't say that this is a nerve tissue. They usually check it, and whenever they see the markers, like either in serum or in the biopsy, whenever we see some proteins that are like neurofilament protein or synaptosine, when we see these markers, we know that this tissue is from nerve because these are representing nerve tissue, synaptosine and neurofilament, and it's easy to remember these markers. Why it is easy to remember? Whenever we see neurofilament, the name itself says that it is coming from neural tissue. Whenever we see a neuronal filament protein in a tissue, we know that this tissue is taken from a nerve ending or a nerve tissue. Whenever we see a neurofilament protein in another tissue, we know that this could be a malignancy from a nerve tissue or a metastasis from a nerve tissue. And synaptosine, whenever we say synapse is also a part of nervous system. So these markers are so easy to remember. Whenever you see neurofilament protein or synaptosine, just remember that these are coming from the nerve tissue. So these are the markers. So what we are going to remember about this part, neurofilament protein and synaptosine, they are the markers of neural tissue. Whenever we see it in a nerve tissue, it's normal. But whenever we see it in a different tissue, this cannot be normal, right? Because they have to be in a nerve tissue. So now let's see about CNS glial cell. We already know about neurons that they have dendrite, they have axon, they have everything. Let's see the picture. This is the neuronal cell. I guess we don't have the, I had it in my slides, so the picture of dendrite and axon and everything like separately, but I'm sure everyone knows that. And about the glial cell, they are made of neuroectoderm. We know that all nervous tissue are developed from ectoderm. We know it from the first day that ectoderm was pulled down, pulled inward with the notochord and made neural crest and neuroectoderm. So all the glial cells are made of neuroectoderm except microglia, which is made of mesoderm. Microglia is the macrophage of the brain, and it is made of mesoderm. This is not very important to memorize all of them. Just whenever you're reviewing first aid, you need to just make it familiar with yourself, just in case somewhere you see a question like that. But they don't usually ask where is microglia generated from or something. But still, we need to be cautious not to see any question. However, I haven't seen any question from this part of embryology. I usually see whenever I say that this is high yield, you can focus on those areas mostly. So CNS glial cell, these are, we are going to study astrocyte, oligodendrocyte, epidermal cell, and microglia. All of them are generated from neuroectoderm, just microglia is generated from mesoderm. And PNS as peripheral nervous system, we know that peripheral nervous system is generated from the crest around the CNS, right, which is called neural crest. Myelin is a cover of the nerve tissue. It is a multi-layer wrapping of the electrical insulation formed around the axon. We already know that it is cover of axon. We don't need to make it longer. We just make it short. Myelin, the cover of axon or the cover of nerve. So it is a multi-layer. As much as I used to think about axons like cable of charger cable or something like that, with their transducing electrical information, right? Transmitting signals. Neuron is transmitting signals, and cable of a charger is transmitting electrical signals, right? So I used to think it like this. Whenever a cable has a lot of layers, especially the cable for iPad and iPhone. They are a little bit thicker than their myelin, or the cover is so thick. So whenever the cover is thick, it takes the information faster. It means that as much as the myelin is thicker, the conduction velocity will be better, right? And the other thing is that this is the myelin that makes saltatory conduction. It means that whenever action potential starts from one part of the neuron, it is transmitted to the other part of the neuron so fast through node of Ranvier. And we are going to study this sodium channel density and node of Ranvier the next day once we arrive to action potential. I hope we can do it today, but because of limited time, we may not be able to do all of them today. So just as non-glial cell from the glial cell from the PNS, we need to remember that all glial cell and the periphery, they are made of neural crest. We already know it from the other day. One of the glial cell and the PNS is myelin, and the other is satellite cell, if you remember, right? The other day we said myelin is the cover of the axon, and as much thick it is, it can take the information faster. So if the myelin is poor, it will not be able to transmit the signals faster. If it is thick, it can take the information so fast. And the myelin inside the CNS, it is called oligodendrocyte, which is from neuroectoderm, and the myelin and the PNS, it is called Schwann cell. It is not divided in first state, but we already know about that. So let's do the cells, the CNS glial cell. Neuronal cell, we know that neuron is neuron. We don't have any specific types. Neuron only has, a neuron is just one type of cell. It has dendrite, it has axon, it has cell body, and it transmit the information. So what are the non-neuronal cell, or the other name for non-neuronal cell is glial cell. Glial cell in CNS and glial cell in PNS. In PNS, we already studied that satellite cell and Schwann cell. Schwann is a myelin, and satellite is also astrocyte of the PNS. So what about CNS? In CNS, we have astrocyte, oligodendrocyte, epidermal cell, and microglia. Astrocyte, we said the other day that astrocyte is a cell that is not neuron. It is non-neuronal or glial cell, a star of the family, right? The other day we said that every family has a star. A star of the family is the one that without that person, the family will be failed. The family will not be able to go on, like they are doing physical support. Whenever, for example, you want to move a furniture from one side of the house to the other side, who is going to help you? This is physical support, right? The star of the family. Repair, whenever electricity needs fix, or whenever TV needs fixation, or whatever, the star of the family comes and repairs it, right? Just remember it this way, not to forget it, because I see questions from astrocytes. We need to know the function of astrocyte. Removal of excess, the trash. Usually the star of the family removes it. Transmitting the information. Neurotransmitters component of the blood-brain barrier. This part, blood-brain barrier, this is the store of the house. Whenever a thief or somebody stranger comes to the house, the store of the family stands in front of you and protects you, right? This is also called blood-brain barrier. Glycogen fuel reservoir brings food for the family. So who is the store for your family today? Does the store of your family do all these things for you or not? For me, yes, of course he does. Like physical support, whenever I need to move the furniture, the astrocyte helps me. Whenever I want to repair something, the astrocytes help me. Whenever I want to remove the trash or excess, the astrocyte helps me. The blood-brain barrier, whenever the store of the family is at home, you are protected, right? And the fuel is the food for the family. And for the brain, glycogen fuel reserves better. So the fuel is also from the astrocyte. So this mnemonic was really helpful for me to remember astrocyte. I hope it is also helpful for you guys. And the marker for astrocyte is also easy to remember. You don't need to remember all the words. Just see this for AP. This is acidic protein, but I used to change it to astrocytic protein, just in order to remember it, because I know that this is glial fibrillatory acidic protein. But if I do it that way, I will forget it faster. But if I say this is not acidic protein, this is astrocytic protein, AP. Whenever you see GFAP in a question, it's okay that you don't remember this word. Whenever you see AP, you know that this is astrocytic protein. You know that this cell should be astrocyte. For example, we have brain tumors that they are originated from astrocytes, like astrocytoma, like glioblastoma, many different types of tumor in adult and children. They are originated from astrocyte. Whenever we see this marker, just remember this one: astrocytic protein, a star of the family, has a tumor. It means that the star of the family has an abnormal growth. So, largest and most abundant glial cell in CNS. So this is the most important one. Star of the family is the most important part of the CNS, right? Reactive gliosis in response to neuronal injury. Reactive gliosis means that the glial cell are showing reaction. Why they are showing reaction? Because a neuron has injured. Whenever a part of the family is injured, who is going to react more? Who is going to be more worried and react and go and take the person to the doctor? So that is astrocyte. So the same thing happens in brain. Whenever a part of the brain is injured, the astrocyte has a faster reaction. This is called reactive gliosis. Okay. And next, we are going to the oligodendrocyte. We know that oligodendrocyte is myelin. We have myelin and PNS, which is called Schwann, and CNS, it is called oligodendrocyte. Oligodendrocyte is myelin. It is cover of the brain. Myelinate axons in CNS, including nerve 2, and it is optic nerve. Optic nerve is coming out of the brain. Other cranial nerves are all called peripheral nervous system, but this is just nerve 2 or optic nerve, which is coming out of the brain, and it has myelin from the oligodendrocyte. Other cranial nerve has Schwann cell as cover, but the cover of optic nerve is oligodendrocyte. That is why this is called a CNS cranial nerve. So oligodendrocyte, the important part about oligodendrocyte is whenever we see in histology, it has the appearance of right egg like this. You see small cells that has a egg inside. So this is the cytoplasm of egg, and this is the yolk of the egg. So you see this type of appearance in histology. We are going to do this and brain tumors. Oligodendroma, oligodendrocytoma is a type of brain tumor which is in the frontal lobe, and in histology you see cells like this. All of them looks like a fried egg. And the same fried egg appearance. Anyone knows where else we see the fried egg appearance and reproductive system? Just try to be interactive and also do integration. Whenever we say oligodendrocyte, we see fried egg appearance in oligodendrocytes. Just remember that where else we used to see fried egg appearance in histology. The other one was this germinoma. This germinoma is a tumor in the ovaries, and seminoma is a tumor in male. Female tumor and male tumor. Just go and check your reproductive system. You see the same fried egg appearance in these tumors. So whenever you see fried egg, just remember that where else you have the same picture, because mostly when you are in one system, you forget the other system. And when you see a question mixed type, you don't understand that this is coming from which system. That's why you have to collect all the same information and find the differences. This is the germinoma and seminoma. They also have fried egg appearance. And so this was an integration from reproductive system. Each myelinates many axons. The characteristic of oligodendrocyte that one oligodendrocyte myelinates many axons. This is not a good thing. However, it has got to have a cover for many axons, but the problem is that once oligodendrocyte is injured, many axons will be affected. At the same time, if we see Schwann cell is in the periphery, and this is the cover of the peripheral nervous system, it myelinates a single axon. So whenever one Schwann cell is affected, just one single axon will be lost. But whenever oligodendrocyte is affected, then many axons will be lost. Predominant type of glial cell and white matter and endured in multiple sclerosis. Multiple sclerosis is an upper motor neuron disease. We are going to study this later on in pathology section. And multiple sclerosis, the myelin sheath or the oligodendrocyte is affected. That's why this is called this glial cell makes the white matter of the brain. So it doesn't matter if we forget the white matter and the gray matter. Just we remember that oligodendrocyte is the cover of nerve tissue inside the brain, inside the CNS, and Schwann is making the myelin or the cover of neurons outside of the brain or in the periphery. Whenever oligodendrocyte is affected, this is called multiple sclerosis. Whenever Schwann is affected, this is called Guillain-Barré syndrome. It means that myelin, either in CNS or in peripheral nervous system, both are important. Either one which will be affected can cause a disease. Like in multiple sclerosis, oligodendrocyte is affected, and Guillain-Barré Schwann cells are affected. In both cases, neurons will not be able to transmit the signals. We are going to study all of these in details later because we need to move on. So we see in multiple sclerosis leukodystrophies and progressive multifocal encephalopathy. This is called PML and multiple sclerosis. Both of these diseases are the same. The problem is in white matter. Progressive multifocal leukoencephalopathy. Leuko means white. Leuko means white. It means the problem is in white matter. White matter is the oligodendrocyte or in the white matter, right? So PML and MS, multiple sclerosis and PML, both are the same. Multiple sclerosis going to be a defect in the oligodendrocyte, and PML is a type of virus which is called GC virus. It's the DNA virus, and that will affect this is because of infection, and this is autoimmune, right? Antibody related. So one is infection and the other is antibody. Both of them have the same picture. Everything is the same in PML and multiple sclerosis, even the imaging. But there is a little difference because multiple sclerosis is autoimmune, and this is the GC virus infection, which is a DNA infection, and this happened in immunocompromised patients like HIV patients. We are going to study this later on. Ependymal cell, we know that whenever we say that tube, neural tube, and D22, we have neural tube. Inside the neural tube, we saw a layer like this. And this layer inside was ventricle, and around the ventricle, we had a layer which is called ependymal cell. Ependymal cell are the cells around the ventricle of the neural tube or around the ventricles of the brain or the spinal cord on the central canal. So ependymal cell surrounds the CSF. So of course, whenever we say ependymal cell or surrounding the CSF, so it has ciliated, simple, columnar glial cell lining the ventricles and central canal of the spinal cord. So ependymal cell has three types of cells. One cells are ciliated. You know, whenever you see cilia and somewhere, you know that cilia is helping with the movement of something. So ependymal cell has ciliated cell, which is helping with the movement of the CSF because it is surrounding the CSF. And it also has choroid plexus cells that they are making the CSF. So these cells, ependymal cells, which are surrounding the ventricles, they have three functions. One function is with their choroid plexus part that they are producing the CSF, and the other is ciliated part, and the other is the choroid part, which helps with the absorption. So, and overall, whenever you see ependymal cell, just remember that ependymal cells are the cells that are surrounding the ventricle. So whenever they are surrounding the ventricle, what is inside the ventricle? Inside the ventricle, we have CSF. So what CSF needs? The CSF needs to be produced. The CSF needs to be absorbed. The CSF needs to move. All of them happens with ependymal cells. With the cilia, it moves. With the choroid cells, it is absorbed. With the plexus choroid, it is produced, right? Let's see the lines of the first state. Ciliated simple columnar glial cell lining the ventricles and central canal of the spinal cord. Apical surface are covered with cilia, which circulates CSF movement, circulation of CSF, and microvilli, which helps with the absorption. Microvilli, wherever you see microvilli and GI system and intestine and wherever, whenever we see microvilli, they have the absorption function. So, and the other part is specialized ependymal cell. They are called colloid plexus. They produce cell, CSF. So, and overall, when this is ependymal cell, they have three functions. Let's go to the microglia. And about microglia, we know that microglia is the macrophage of the brain. Macrophage in each part of, for example, in GI system, we call it reticuloendothelial system, and when CNS, we say microglia, so the name changes every year, but the function is the same. They have they protect the brain, and they have the immunity function. Microglia activation and response to tissue damage. Whenever a tissue is damaged, one thing was astrocyte, that it was coming astrocyte, right? Astrocyte. Whenever you see tissue damage, don't forget astrocyte, because astrocyte is also coming. But macrophage is also coming for in response to tissue damage. That this is coming for repair, and this is coming for the help, right? For the immunity, for defense. So the purpose of each is different. So at first, macrophage is already there. It helps with the defense, and later on the astrocyte comes, right? So just remember this, because you don't need to confuse these two terms. So activation, when the microglia starts to work in response to tissue damage. Release of inflammatory mediators like nitric oxide and glutamate. We know that glutamate is cell excitatory, and it causes action potential, and nitric oxide is a substance which is causing vasodilation, right? And we need, for inflammation, we need vasodilation so that the vessel is large enough so that all the cells come to the area of the damage. And why we need a nitric oxide and vasodilation? Because lots of blood supply should come to the area, should bring neutrophils to the area, should bring blood to the area, so that the damaged area is helped. That's why we need nitric oxide and glutamate. And glutamate is causing cell excitation and action. It's causing action potential. We are going to read all of them slowly in neurology. These are so interesting. Believe me that is one of neurology and biochemistry used to look so difficult for me, but now that I'm done with step 1 and step 2, I really love them. I don't want to forget them. That's why I want to teach, because I want to record and keep them, because they are so interesting. I don't want new doctors, they're beginner doctors, to be afraid of these two systems, because they're so friendly. Once you understand the way how to maintain them, then you will also like them the same way as I do. So microglia not readily discernible by nasal stem. So we already know that nasal stem is only for the dendritic cell and cell body, because they have rough endoplasmic reticulum. What is the function of microglia? Phagocytic scavenger cells of the CNS. They have the function of phagocyte, right? They do the phagocyte. Neutrophil and macrophage are phagocytic scavengers, but for the brain it is macrophage. HIV infected microglia used to form multinucleated giant cell and CNS and HIV-associated dementia. This is very high, multinucleated giant cell. Multinucleated giant cell we see in different type of diseases. Multinucleated giant cell means that multi macrophage, 1 macrophage, 2 macrophage, 3 macrophage, 4, 5, all of them get together. They make one cell, one big cell, right? This is one big cell. They have multinucleated. Why they are multinucleated? Because different macrophages are gotten together. So 1 macrophage, 2 macrophage, all of them gets together and make one cell. This is one cell, but it has multinucleated. This is one nucleus, the other nucleus, the other nucleus. So if we say joint cell, this is joint cell because it has one nucleus. But whenever we say multinucleated joint cell, it means that, of course, it is a joint cell, but it is made of many other cells, because in some of the viruses do this to the macrophage. All the macrophage get together and make a multinucleated joint cell. And one of them is herpes virus and cytomegalovirus and HIV. All of them are RNA and DNA viruses. And micro is also, let me say that micro is also very interesting. So all each system and each subject of this book is so interesting if we read it the way that we have to make it interesting and fun. So now that we know that multinucleated giant cell, we know that multiple macrophage with their nucleus get together and make one cell. And this one, we usually see it and rare in patient with HIV. HIV-associated dementia means that the patient with HIV also has forgetfulness. And whenever we don't know that this forgetfulness is due to which disease, we do a brain biopsy. In brain biopsy, we see, whenever we see multinucleated giant cell, we know that this multinucleated giant cell can be either due to HIV, due to cytomegalovirus or herpes virus, but HIV has its own characteristics. So, and HIV-associated dementia, this is the characteristic, and this is very high. Just try to remember this for the exam purpose. And the PNS cells, we know that we have glial cell in the PNS, and the PNS glial cells are satellite cell, which is equivalent to astrocyte. This is the star of the family for the peripheral nervous system, and Schwann cell is the cover of nerve tissue in the periphery. Satellite cells surround the neuronal cell bodies and ganglia. We have ganglia in the dorsal column and also in the inside the cell bodies and ganglia in the peripheral nervous system. So this is not important that we are the satellite cells are, but the most important part is that satellite cell or has similar supportive role like astrocyte. This is important to remember. Schwann cell, it is the myelin of the axons and peripheral nervous system and also cranial nerve 3 to 12. Just cranial nerve 1 and 2, they are oligodendrocyte. The others are the cover for other nerves. The other nerves are all Schwann cells. And the marker for Schwann cell is S100. S for Schwann and 100 plus. It means this is the marker. Whenever you see S100 in a question or in biopsy, you just remember that S100 is for Schwann cell, and Schwann cell comes from neural crest, right? We already said that peripheral nervous system is generated from neural crest. Peripheral nervous system, right? From neural crest. And Schwann cell is also a part of peripheral nervous system. Peripheral nervous system is made of neural crest. We know that this neural crest not only makes the Schwann cell, it not only makes the peripheral nervous system, but also it goes to the heart, it makes in the cardiac portion, it goes to the GI system, makes the enteric nervous system, it goes to the adrenal gland, it makes the medulla of the adrenal gland, and also it goes to the skin, it makes melanocytes, right? Melanocyte. So whenever we see S100, we remember that this is a problem in neural crest cell. And this S100 is positive in melanoma and also in schwannoma. Just remember this. We can see this, we may see this S100 and many other tissues that are originating from the crest cell, but the most important one is the Schwann cell and melanocyte cell. Why? Because we have tumors. They are very dangerous tumors, melanoma and schwannoma. In melanoma and schwannoma, we usually see S100 positive and see these in questions. I already said that whenever Schwann cell is affected, it is called Guillain-Barré syndrome. And this is a photo of the neuron. I'm going to explain node of Ranvir and everything the next day. The time is over for today. I hope you enjoyed the lecture for today. And thank you so much for your time and for your patience. I need to stop the record. If you have any suggestion or question, just let me know.